All right. So thank you guys for joining. I am going to turn my camera off only because my computer really struggles if I have both going at once. And I apologize if you hear any grumbling from my dog in the background. But thank you guys for joining. I have the meeting chat up, and so I'm able to see all your comments and questions and everything else. I'm Andra Farkas. For those of you guys that I do not know, I'm an emergency medicine and EMS physician at the University of Colorado. And welcome to our Rural EMS Education Series for December. We are a little off schedule here just because I had some conflicts, but thank you guys for joining. We're going to be talking about out-of-hospital cardiac arrest. And so we will jump right in. Feel free to unmute yourself or pop questions in the chat as we go. I definitely have no conflict of interest to declare. All right, so this is what we're going to be talking about today. We're going to do a little anatomy and physiology. I promise it'll be little. And then we'll talk about the pathophysiology of out-of-hospital cardiac arrest. We'll go a little bit into epidemiology, both nationally and at a state level. We'll talk about ruralology and how everything's a little bit different when you're talking about cardiac arrest in the rural world. And we'll talk about interventions, some of the interventions we do, not all of them, and the science behind them. For this last point, this is not going to be a mind-blowing talk. We're not talking about anything that's new or a magic bullet in the world of cardiac arrest. It really will be a refresher on the aspects of high-quality resuscitation and a little bit on the science behind them, basically why we do the things that we do in this particular clinical scenario. All right, so let's jump right in. Because you can't talk about the normal without talking about the abnormal, let's do a quick refresher on anatomy and physiology. So you guys, just so we're all on the same page, I'm sure you all remember, but the blood flow through the heart, the deoxygenated blood comes back from the body through the vena cava, returns to the right side of the heart, which is pumped to the lungs. It gets nice and loaded with oxygen and then goes back to the left side to be pumped throughout the rest of the body. One important thing to remember is that that is also how the heart pumps blood into its own coronary artery, so how it perfuses its own coronary arteries as well. When we're talking about electricity, this is really the stuff that's important for cardiac arrest. But remember, this is kind of the normal pathway that electricity follows in the heart. It starts all the way up here at the SA node, moves down the atria to the AV node, and then moves down the branches and Purkinje fibers to squeeze the ventricles. As the electricity moves, this contracts and then moves on to the ventricles. If you guys remember kind of how everything corresponds to the EKG, once the SA node fires and the atria contract, you see that P wave. Then when they start to relax and the impulse moves, you start to get the beginning of that QRS. And once the ventricles are fully contracted, you end that QRS. And then you have a little bit of a refractory period of the T wave while the whole process starts over and over and over again, about 60 to 90 times a minute. So that's the normal. Now let's talk about the abnormal. Sudden cardiac arrest or sudden cardiac death is what we're obviously talking about here. And this is when you have a cessation of cardiac activity with hemodynamic collapse. That is the definition of it. And it's usually due to a sustained arrhythmia, a ventricular arrhythmia, a tachycardia, or a fibrillation. Now, how do we know this? How do we know that it's usually due to VT or VFib? People don't walk around with Holter monitors 24/7, right? So we're not capturing their rhythm. But we've done studies looking at patients who do have monitors, such as those that are in the hospital or those who have ICDs. And that's kind of where we get this data from and why we think that majority of patients have VTAC or VFib that may devolve certainly into other rhythms. A smaller percentage of the time, it can be a bradyarrhythmia, and you don't see that tachyarrhythmia, so the ventricular tachycardia or fibrillation. I'm sure we've all seen that sick patient who's braided down at the cardiac arrest, but the vast majority of the time is VTAC or VFib. Brief reminder of what VTAC and VFib are. So remember that nice pathway we talked about where it moves down the atria and the ventricles. Well, in VTAC, the ventricles kind of take it away and have this re-entrant rhythm. So you're not even seeing P waves, you're just seeing big, wide, ugly, scary complexes. Obviously, if this doesn't have a pulse, then that's when you're worried. And then polymorphic, just to show you another picture, won't go into the details about how that's different. And then certainly VFib is the other one we talk about. Now, this is the one people think of as VFib, but remember, you can also have pretty fine VFib that can be pretty hard to interpret. Now, that may look like asystole, or it may look like asystole if you're driving down a, bumpy dirt road. But this is technically fine VFib, which is still a shockable rhythm. All right, so why do people go into cardiac arrest? What predisposes them to it? For about 65 to 70% of patients, it's because of coronary artery disease. Now, this doesn't mean that they have an ST elevation myocardial infarct. And actually, a lot of the time, there's no evidence that they had an acute infarct. It's thought that there's more so ischemia, so a lower blood flow rather than a complete stopping of the blood flow. That is the precipitating cause. Now, if someone comes in and has cardiac arrest and we get them back and we check some blood work, we check biomarkers like a troponin, these things are going to be high. But remember, that's because your heart is damaged in some way. We don't know if that's because they had an ischemic event that led to them going into cardiac arrest, if it's because of the arrhythmia they were in, or if it's because of what we did to treat them, the chest compressions and the electricity. We can't really elucidate chicken or egg in that situation. But we do know that the frequency of coronary artery disease is really quite low in younger patients. Patients under the age of 30 or 40 who have cardiac arrest tend to not have coronary artery disease. 10% is due to some other type of structural heart disease. So I guess I've heard of those, cardiomyopathies like HOCM, or which is hypertrophic cardiomyopathy, or some congenital abnormalities of your coronary arteries. Even myocarditis, an infection or inflammation of the heart, can cause this. 5 to 10% have no structural abnormalities, meaning that their heart is structured completely normal, but they go into an arrhythmia for another reason. These are the folks that when we're looking at an EKG in somebody who passed out or had syncope, we look at the long QT syndrome. We look for Brugada. We look for all those fancy things that are named after people, Wolf, Parkinson, White, etc. That's what this means. This is that 5 to 10%. And then anywhere from 15 to 25, if you do the math, that doesn't fully add up to 100, but go along with me here, of cardiac arrest are non-cardiac in origin. So that means that there's a secondary reason that caused it. Things like trauma, hemorrhagic shock from bleeding, potentially intracranial hemorrhage or pulmonary embolism, et cetera, et cetera. So that's kind of the breakdown of what causes out-of-hospital cardiac arrest. Now, let's get a little nerdy and kind of dive into the numbers, aka why does this matter? So as you are all aware, this is not a rare entity to have out-of-hospital cardiac arrest. According to the AHA, each year there's about 350,000 adults who have this and about 7,000 pediatric patients who have it. Let's talk about how those patients do. This is from the CARES registry, which if anyone on here is not familiar with that, it's a nationwide registry of cardiac arrest that covers a pretty nice catchment of the country. It's like almost 200 million people population-wise, a bunch of states, et cetera, over 2,000 agencies and hospitals. And so a lot of these agencies will send their data on cardiac arrest. In 2023, since obviously we don't have the 2024 numbers yet, there were almost 140,000 arrests that were reported to this registry. And you're seeing a big difference from the 350 that we discussed on the last slide. This is because the CARES arrests are a very specific set of arrests. So it's a non-traumatic cause where an EMS provider tried to resuscitate the patient through CPR, AED, et cetera. So that is the 140,000 that are captured. Excuse me. Nationwide, 41% of those patients got bystander CPR. EMS responded in a median of 7.6 minutes, and about 27% of those got ROSC and kept it with EMS, so in the field. So remember those numbers. While 41% of patients had a bystander do CPR, only 11.7, so almost 12%, had a bystander apply an AED. And this was only patients who arrested in public. So this does not count the patients who arrested in their own homes. 26% survived to hospital admission. 10% overall survived to hospital discharge. And of those 10%, almost 80% had a positive neurological outcome, which if you guys hear the word CPC score thrown around, this is what this refers to. It's a CPC score of 1 or 2. You've probably heard it, but what does that really mean? Unless you're really getting deep into the CARES data, probably no. So a 1 or a 2 is basically you have a full recovery, or you have a very mild disability, or perhaps you have a moderate disability, but you're independent in your ADLs. So you're able to kind of take care of yourself, maybe have a job. So pretty much back to normal or as close to it as possible. That is what we say a neurologically positive outcome is. Otherwise, 3, 4, and 5 start to get progressive states of disability. Okay. But how does Colorado kind of stack up against the nationwide numbers? First, as a quick aside, because I know a couple people join here from other states, apologies for the Colorado-centric nature of the stats. However, any state that collects CARES data and sends it to the registry should have this publicly available. So if you're joining in from somewhere else, Google it, look it up, see how your state stacks up. You should be able to find it. 2, I've been doing EMS in some shape or form for like 3 states before I moved to Colorado. And this whole core business, kind of like the nasal intubation, was something that I'd never seen before. So if anyone's joining from a state where they don't use this terminology, when we talk about a core or a core 0, this is what we're referring to, which is cardiac output respiratory effort 0, a core. I don't know of any other state that uses it, but just so we're all on the same page. All right, so Colorado. For Colorado's 2023 CARES data, we have about 70 agencies that send their data and covers about 80% of the state's population. So pretty good look at how our state is doing. We had about 2.5% of the 140 cases nationwide, so about 3,500. I thought this was interesting. The average age was about 60, and the vast majority of them happened at home rather than in a public place. You may think that that means you're predisposed to have a lower chance of bystander CPR. There's only one other person there that maybe they don't know how to do it. But we actually had a slightly higher rate of bystander CPR in Colorado than nationwide. It was 43% compared to 41%. When it comes to bystanders putting on AEDs, Colorado data is reported a little differently, so it's hard to kind of directly compare between the national numbers and Colorado's. But overall, 5 1/3% who arrested in Colorado had a bystander apply an AED. So that includes everybody, regardless of where they arrested. However, when you look at this number, a good majority of them arrested in a nursing home or some other type of healthcare facility that wasn't a hospital. So that data is a little bit skewed about true bystanders. Compared to the national 26.1, we have 25.4% that survived hospital admission. And then compared to the national 10.2, we're at 10.8 hospital discharge survival. I do want to point out the difference between when there's bystander CPR survival and when there is no bystander CPR, 13.5 versus 7. That's obviously quite a big difference, almost double. And then finally, compared to the 79.6% nationally, we actually had 89.6, almost 90% of patients who made it to discharge did so with a good neurological outcome. That's 384 people. So that's 384 people who walked out of the hospital in 2023 and are able to function independently because of what EMS providers are doing. And that's pretty awesome. That's a lot of people. And that's because in this kind of chain of survival that the American Heart Association talks about for cardiac arrest, the first 4 of the links depend on pre-hospital events, right? Specifically, kind of bystander interventions and then what you guys are doing. So that early recognition of cardiac arrest and activation of the emergency response system, that early CPR and early defibrillation, and then obviously the advanced resuscitation that you bring when you get to scene. I do want to point out that we do a really bad job about teaching pediatrics often along with kind of the general population. And so I do want to point out that the actions of pre-hospital providers are also obviously very crucial in this chain of survival, but it's a little bit out of the scope of this talk for me to talk about pediatric out-of-hospital cardiac arrest, just a brief reminder, and then we'll kind of talk about it more generally. All right, so remember that median response time nationally of 7.5 minutes. That's pretty impressive, right? That's under that 8 mark. And as we all know, and we'll kind of talk about later, this is great because early CPR, early defibrillation is really important. Ideally, that early CPR and defibrillation is done by bystanders, but if you don't have that, then we really rely on EMS getting there in a timely manner, first responders and EMS. And the 7.5 minute time, totally reasonable when you're talking about an urban or even a suburban area. But when we're talking about rural and frontier, as you all know very intimately, you're looking at much longer response times, right? Especially if you have a volunteer system where folks are coming in from home, right? They have to turn off their stoves, leave dinner half cooked, and then drive in from home. Now we're talking 20 minutes, 30 minutes, possibly even longer, especially if you're some harder to reach areas of your response district. And Steve asked if there's a difference between urban and rural survival rates. Thank you for that planned question, Steve, because that's what I'm talking about next. So how does that urban versus rural affect outcomes? And what does the data show about that rural response to out-of-hospital cardiac arrest? This is just one study that looked at it nationally and basically found that compared urban and non-urban, so it was urban and everything else, suburban, rural, frontier, etc. They found that non-urban out-of-hospital cardiac arrest had longer median times to defibrillation, 8 minutes versus 6 minutes. So it took about 2 minutes longer to get defibrillated. If you had an arrest in a non-urban area, then you were less likely to receive an advanced airway management, 6.5 versus 11.5. And you were less likely to get ROSC in the field, 32 versus 38. Obviously, you had a lot longer of a distance to your hospital with your post-resuscitation care, if you're, transporting once you have ROSC, ongoing for 27.3 miles rather than 5.7 if you're urban. That's a lot of miles. If you're driving, let's say, 60 miles an hour, right? That's a difference of almost 22 minutes. 22 minutes longer you have to spend in the back of the rig with that patient in a rural area. And somehow, despite the very similar rate of bystander CPR between urban and non-urban areas, they're about 53 and 54% respectively, survival rates to hospital discharge were much lower in the rural or non-urban rather than urban. Now, they changed some covariates here, and the differences were no longer as pronounced or statistically significant once they kind of adjusted for covariates, but it's still a pretty striking number to look at. So yes, there's definitely a difference between urban and rural survival rates. And like I've said before, I know some folks, agencies and providers are tuning in outside of Colorado. So again, excuse how Colorado-centric this data is. But I think the bigger picture really applies to kind of rural agencies anywhere in the country. These next few slides are data from the 2023 Emergency Medical and Trauma Services annual report that they present to SEMTAC and really paint a good picture of kind of the rural nature of EMS that we're dealing with in this state. Like this graph. More than half of agencies in the state of Colorado run less than 1,000 calls a year, and a good number of those run less than 500. So rural, low volume. A good number of counties have less than 500 911 incidents a year, right? These kind of lighter color. So again, rural, low volume. And Colorado EMS is mostly ran by BLS providers. If you look at the breakdown, the vast majority, 70%, are EMTBs. We have some EMTIV, EMTB and IV, this is lumped together, whereas only about 28% are medics, and then we also have EMTIs and AEMT. So with all the challenges of treating out-of-hospital cardiac arrest added to the challenges of rural EMS, how do we take the best possible care of these patients? So let's start an EMS talk by discussing things that are outside of EMS control, specifically what bystanders do in out-of-hospital cardiac arrest. Okay, so this isn't entirely out of EMS kind of realm of influence, since I know many agencies hold CPR classes and other trainings in their communities. Like those 3 rings, the first 3 rings of the chain of survival, we really want to teach bystanders to recognize cardiac arrest, to call 911, start CPR, and then get an AED if it's available. And I'm sure that's what many of you guys are teaching in your communities to your bystanders and your lay rescuers. with COVID, there's certainly been a lot of changes in training, and this area of training was not left unchanged by COVID. But the good news is there's some data that actually shows that whether it's a combination of self-instruction and instructor-led teaching with hands-on training, or just an instructor-led course, there's no difference in how people do. So there's some studies that compared self-instruction or video-based, so you're watching a video about how to do CPR, with taking a class led by an instructor, and they found no difference in performance that was significant. And certainly if we, kind of shift towards a more self-directed learning, then we may have more community members take the classes, right? Watch those videos. And so we'll have more trained lay rescuers. So the takeaway is keep holding those CPR classes in your communities. Obviously encourage your members to participate, but seek out some approved videos. The AHA has them and a bunch of other organizations. And like post them on your Facebook pages maybe, or, other social media, link them on there. And importantly, also, we think about teaching adults, but we also should be teaching middle school and high school age kids how to do CPR, because they're very capable of doing it. They're not too young to learn.
Dr. Farkas?
Yes.
Is there any data whatsoever, especially on rural dispatch centers, on efficacy of getting CPR initiated through formal emergency medical or EMD dispatch programs?
That's a great question. I will be talking about telecommunicator CPR, but I do not have the specific breakdown with rural versus homegrown dispatch versus a more formalized medical priority dispatch, but I'm sure it's out there. I just don't have it specifically ready. That's a great question. But we will talk about dispatcher CPR. And then the other thing is, resources, right? So one other thing that agencies can do is really kind of help businesses and other communal areas navigate the world of initiating and maintaining an AED program, so that you don't only just have lay rescuers who know how to use an AED, but also actually have access to one. There's a lot of studies out there that support the positive effect of bystander CPR and AED use, and this is just one of them. But this is the data that was taken from the study I just talked about, the one that looked at urban versus non-urban cardiac arrest. And it basically shows that no matter what setting, so urban, suburban, large rural, et cetera, does not matter. When you look at no bystander intervention, which is this line, compared to bystander CPR and bystander CPR and AED use, it makes a huge difference. And these are odds of neurologically intact survival. So 3 times the odds compared to nothing when you use an AED and do CPR in a rural area. And so the big takeaway is it makes a huge difference no matter where you are, bystander CPR and bystander AED use. We have definitely shifted to teaching lay rescuers compression only CPR a long time ago. This is not new, but there's also data to support this. In Japan, they actually started a nationwide dissemination of kind of chest compression only CPR teaching for lay rescuers. And they saw a pretty impressive increase in incidence of survival with favorable neurological outcome. So big takeaway is bystander CPR works, bystander AED use works. And since, again, I had a plant in the audience, let's talk about telecommunicator CPR. So once someone's kind of activated 911, how can dispatchers, telecommunicators help with those other 2 first rings in the chain of survival? First of all, we used to have people check a pulse, but somebody who does not have medical training is understandably not going to be good at finding a pulse. And when they do, it's going to take a while, right? To kind of get to that area to feel it. And so that's why we don't have dispatchers check pulse anymore before starting CPR instructions. If they're not learned breathing, they start CPR. Additionally, agonal breathing is actually present in about 40 to 60% of out-of-hospital cardiac arrest at first. And to a layperson who is not trained in any type of medical anything, then it could very well look like just normal breathing, right? They could describe it as snoring, gasping, maybe abnormal breathing, but it can really throw them off. Like, are they breathing? Well, yeah, there's air coming in and out, right? And it's actually cited as a common reason for why lay rescuers miss the fact that the patient is in arrest. So that's why it's so important for our telecommunicators and our dispatchers to pick up on that, are they breathing normally cue, to recognize when they're not, or use their cues. There's like an agonal breathing tool to be used to kind of verify if that's the case. This is by no means a recent change, but that's why kind of our dispatchers are starting CPR instruction process in a patient who is unresponsive and has absent or abnormal breathing, even if they're breathing, but it's abnormal. And the good news is that this is a highly sensitive approach, but it doesn't actually cause any harm to patients if they're not in cardiac arrest. There was this systematic review that they looked at, to see if there was any adverse events. And they found that when somebody initiated CPR on somebody who was not in cardiac arrest, they had a really low risk of adverse events. So they had 8.7% had pain, obviously, in the area of the chest compressions. 1.7 had some type of bone fracture, whether rib or clavicle. 0.3% got rhabdo, which I thought was interesting. But there were no described visceral injuries. So they didn't hurt anything internally. So it is pretty safe to recommend CPR when someone is unresponsive and not breathing, even if they technically still have a pulse. And there's a lot of studies, like I was saying, that support telecommunicator CPR. Sometimes you'll see it DA CPR, dispatch assisted CPR. But this is one that I think is pretty powerful visually. It's from South Korea, actually, where they collected data before and after the implementation of a nationwide telecommunicator CPR process. The number of bystander CPR increased by 3.5 times almost after the intervention. And then they also had good neurological outcomes that increased by 2.6 times. Granted, they started at 2.9% bystander CPR and went up to 10.3, but still over the course of a couple of years, and that's still a pretty impressive improvement. And then their survival to discharge went from 3.5 to 5, and a good neurological outcome from 1 to 2.6%. So basically, telecommunicator CPR is an awesome tool, and it works. All right. Now I'm going to move on to some EMS interventions, unless anyone has any questions. All right. Let's start with CPR. We all know that high quality CPR is this thing that we say is good, right? But what really defines it as high quality? There's a couple of main tenets, which is minimizing interruptions, doing an adequate depth and rate of compressions, and then making sure you let it recoil in between compressions. And there's actually data for this. There's one analysis, I think it's a combined analysis of it's about almost 13,000 patients that really kind of confirms the importance of depth of 2 to 2.5 inches, 2 to 2.4 inches for an average adult size, and then that rate of 100 to 120. This study found better outcomes, including survival to hospital discharge, and also importantly, defibrillation success. And the minimizing interruptions, I'm sure you guys have all seen this graph at some point during your EMS training, but this is from a 2012 paper that describes kind of what happens to perfusion of vital organs when you pause CPR. And this is why we really harp on that continuous CPR for lay rescuers, and then on minimizing interruptions as much as possible and making them as short as possible. Because when you start compressions, right, your perfusion pressure, so the pressure you have to give oxygen to important things like your brain and your heart, goes up. You kind of reach a nice plateau, but then the minute you stop, it drops immediately right back down to as if you never did any, right? So that's kind of why we really, really, really harp on having as little of interruption as possible and having as short of interruption as possible. Why do we switch out compressors? And how do we really know how frequently to do it? A couple of studies found that chest compression depth begins to decrease after 90 to 120 seconds of doing CPR. So no matter how good you are at CPR, no matter how great of cardiovascular shape you're in, you're gonna start doing a slightly less good job by 90 to 120 seconds. And there was a study that looked at mannequins, that looked at if there's a difference in the quality of compressions if you do switched to a new compressor at 1 minute versus switching at 2 minutes, and they found no difference. So obviously rotating at 2 minutes makes the most sense, because not only do you maintain that like good quality, but also obviously you take advantage of that pulse check, rhythm check, etc. So it's a good pause. So there is some data behind why we switch at 2 minutes. All right, lay rescuers are obviously taught compression only CPR. EMS providers are taught to deliver both compressions and ventilation. The why on this one is pretty obvious. If you're just delivering chest compressions without assisting ventilations for a long period of time, it's going to be less effective than if you're also ventilating. The oxygen content of your blood is going to decrease as the CPR duration increases. And that's obviously going to have a bad outcome, right? What you're trying to do with CPR is get that oxygen to those vital organs. And if your bloodstream doesn't have oxygen, you're not going to get oxygen to those organs. So if you're not ventilating and oxygenating, you're just going to run out of oxygen, have a bunch of CO2 running around. The head tilt chin lift, there's actually data behind that as well. It's been shown to be an effective way to establish an airway in non-cardiac arrest studies and radiological studies. So they took a bunch of, CTs and x-rays and stuff, but there's no actual comparison of head tilt chin lift with other measures in cardiac arrest. However, there's a lot of this stuff where we just extrapolate the data and say, well, it works in this, so will probably works in this as well. And so that's kind of what we're doing in cardiac arrest. There's also no evidence looking at using an OPA or an MPA during arrest, but obviously we all know that when they're used properly, they're a really good tool to get the tongue out of the way so you can get better ventilations. I don't know if anyone's still doing cricoid pressure, but there is actually no evidence that cricoid pressure does anything to help ventilation or does anything to help reduce the risk of aspiration in cardiac arrest. There's some trials in non-cardiac arrest that maybe it can help protect against aspiration and against kind of filling up the stomach with air when you're backing somebody, but it also can impede ventilation, and then it can make it harder for you to put a supraglottic airway in or to intubate. So really, we're not doing that anymore. We're definitely not doing it in cardiac arrest. And then once you do get to ventilating, the science really supports that old 30-2 method. There was a systematic review a couple years ago that found that 30-2, so 30 compressions to 2 breaths, had better survival than a bunch of other ratios they tested. And then the AHA kind of took up this recommendation a couple years ago as well. And actually, a couple studies even found that there's no difference between the 30-2 and the 10 breaths per minute that we do with an advanced airway. So the 30-2 with the BLS rescue team is perfectly reasonable. All right. And then to wrap up the BLS portion, my absolute personal favorite topic, which is end-tidal CO2. To do a little physiology review first, I think of end-tidal CO2 as really just the amount of CO2 in the alveoli, which I think it is, and it's less confusing for me to think of it that way. So in a patient who's breathing by themselves, if their end-tidal CO2 is low, that means that they don't have a lot of CO2 in their alveoli. So when it's coming from the bloodstream, it's not sticking around, and that's because they're breathing it out really fast. So if somebody is hyperventilating, they're going to breathe out all their CO2 and it's going to be low. Now, if it's high, the opposite is true. They're not breathing well enough. So it's going from the bloodstream to the alveoli and it's just hanging around there, and they're not doing a good job of breathing it off. But there's a second part to this equation, which is the amount of CO2 in the bloodstream that's being exchanged with the alveoli. And that's why we use CO2 in shock, for example, because it's a marker of perfusion. So your end-tidal CO2 will be low, even if you have a normal ventilation rate. Okay, that's great. But why do I care about it in cardiac arrest? Because it's a really, really, really good marker of how well we're resuscitating, how well we're doing chest compressions. And then obviously when you're managing an airway, how well we're ventilating the patient. There's a bunch of data on this, but one I want to talk about is an analysis on some Get With The Guidelines data. So it's a giant registry with a whole lot of data in it that showed that there's a higher likelihood of getting return of spontaneous circulation when the CPR quality was monitored using end-tidal CO2. For every 10 millimeters, your compression depth increases. So when you do slightly better compressions, your end-tidal COT increases by 1.4. And then we think of end-tidal CO2 as a prognostic indicator. It's not quite as good at that in general, but what one study did report is that if it's less than 10, you're going to probably have a poor outcome. If it's greater than 20, you're going to have a stronger association with ROSC. So the combination of those two basically just really tells me that targeting your chest compressions to a value of at least 10, ideally 20, on your end-tidal CO2 is going to be a great way to make sure you're doing the best possible chest compressions. So the takeaway message here is use your tools. Use end-tidal CO2 to help guide your resuscitation. It's easy, it's non-invasive, it's not very expensive, and it can really help improve outcome. There's a bit of a caveat here because it's not quite as the validity and reliability, if the patient isn't intubated, isn't well established. It doesn't mean that it doesn't work. If it's an iGel or some other BLS measures, it just means that we haven't really studied it well enough yet. But I'm still a strong believer in using end-tidal CO2. All right, I'm going to move to some ALS interventions, unless anyone has any questions on the BLS ones. All right, great. We're going to start with defibrillation. And a question for you guys, and you can type your answers in the chat. You show up on scene, you see a bystander doing great chest compressions. What's going to be your first move? Are you going to take over? Are you going to do a pulse check? Or are you going to put pads on? Steve says, apply pads. Great, because they've heard me talk about this in the past. Awesome. C seems to be the, yeah, all right, there's no fooling you guys. Great. The key to this whole thing is that they're doing chest compressions, and they're doing, the key is that they're doing great chest compressions. CPR is obviously the single most important intervention for a patient in cardiac arrest, right? And so we need to keep doing that until a defibrillator is ready to go. We can minimize interruptions and compressions, because remember, we said that's key for a high quality resuscitation. When a shockable rhythm, VFib or VTAC, has been present for more than a couple minutes, the heart understandably runs out of reserves, right? It runs out of oxygen, it runs out of ATP and all those other energy substrates that it uses. And so the way to replenish those is by doing CPR for a little bit. And if you do that, then the likelihood that the defibrillation will work is a lot greater, because the heart is kind of like ready to accept that defibrillation because it has all this oxygen and resources. So you guys got it, but the big takeaway is take a couple seconds to put the pads on if they're doing really good high quality CPR. So you're minimizing interruptions. You're not having the interruption of someone taking over. And then you're ready to shock them when you're ready to kind of switch compressors and do that pulse and rhythm check. Now, if someone goes into shockable arrest right in front of you, that early defibrillation is really going to be key. When it's been just a couple of seconds of VFib or VTAC, then the heart still has all those reserves of oxygen and energy. And so they're going to be it's going to be pretty responsive to a defibrillation. So if you watch somebody kind of, go into it in front of you and you have the pads on, or you have them nearby and ready to apply, it's reasonable to try to shock as soon as possible. If it's going to take a while, then obviously you're still going to do CPR. But if you're ready to go, then go ahead and shock them. And that's why we kind of really harp on putting the pads on for patients with a STEMI or anything else, any other conditions that kind of make us wary that they might go into an arrest. They may decompensate, so that we can be ready and able to shock them right away. We also know that keeping the pauses around shocks as short as possible is good, both pre and post shock. And there's a couple studies that kind of report better rates of ROSC with shorter pauses. And so that's why we kind of harp on that pre-charging the monitor while the chest compressions are still ongoing as you're getting ready to do your pulse and rhythm check. Because if you're pre-charged, then it's going to be a shorter time that someone is off the chest. And we know that that's going to be associated with the better survival. And then we go right back on the chest after the shock, no matter what, right? Because even when a defibrillation is successful, it may still be followed by a period of asystole or PEA while the heart is kind of figuring itself out. And so doing CPR while you're waiting for that to for the heart to figure it out is also going to be the move there. And so that's where you're right back on the chest. There was a couple of studies that looked at whether stopping and analyzing the rhythm right after shocking changed the outcome, and it showed a worse outcome. So that's why we get right back on the chest after we shock until the next time, or until the patient's, sweating you off because you fixed them. All right, now for something a little more controversial. You guys may have heard of this study from 2022, the defibrillation strategies for refractory VFib, or the DOSE-VF trial. This was a pretty big deal. It came out in the New England Journal of Medicine a couple years ago. What they basically did was a randomized controlled trial, so the highest level of evidence. This was in Canada. They looked at 405 adults who had out-of-hospital cardiac arrest, and specifically those who had refractory shockable rhythm. So that means that they had VTAC or pulseless VTAC or VFib. They shocked them 3 times the regular way. They did CPR and they couldn't get them back. They were still in a shockable rhythm. So then what they did was they split them into 3 arms. Either they kept doing the same thing, so shocking with the same pad placement. They changed the vector. So instead of that anterior lateral, they did more of an anterior posterior vector. Or they put a second monitor on and shocked them with double the dose at the same time. And then they looked at survival to hospital discharge. They found that those who had the double sequential, so the 2 shocks at the same time, did the best for survival to hospital discharge. Those who had vector change did pretty good. And then the regular old same thing had the worst outcome. Obviously, the double sequential defibrillation is not something that's always going to be possible to do in a rural setting. You don't always have a second ALS unit who has a monitor ready to go. And some people are nervous about, frying the monitors and everything else since they're so expensive. Of note, there were no monitors that were harmed in the making of that study. So it's actually a pretty safe practice. But understandably, you may not have access to 2 defibrillators. But if you look at this, the vector change, it still had a pretty improved outcome compared to the regular way of doing things. And so, it's kind of explains why some of your protocols may recommend vector change if you've shocked them a couple of times and it's not working. This wasn't a perfect study. It was actually stopped early because of COVID, but they still had 400 patients. So it's still a pretty important study to be aware of.
Dr. Farkas, I have a question.
Yes, ma'am.
I'm wondering if, I know us in our rural setting, we most of the time carry AEDs with us. Would that be possible to do with an AED and a heart monitor? The double?
Yeah, that's a good question. If it's a type of AED that you can override and set into manual mode rather than automatic, I feel like you probably could, but not every AED has the capability to do that.
Oh, okay.
Yeah. Because you'd have to time it with the AED shock. So that'd be, if it was like the automatic shock, it'd be hard to time it with the automatic shock. And this study didn't specifically look at that, so I can't comment on if that works as well. But theoretically, I can see why you could, but there's not, I think, enough data to support that.
Okay. All right.
Good
Thank you.
question. Yeah, good question. All right, now we're going to talk about another somewhat controversial topic, which is epinephrine. So I think we all agree that epinephrine generally increases ROSC and increases general survival. But we also obviously care about neurological recovery. And when we look at outcomes 3 months after someone gets ROSC, which is really the time point that we feel like we can make a good call on how they're doing from a neurological standpoint, epi doesn't really do anything. Any drug that's going to increase your rate of getting ROSC back or survival is going to have an effect on your neurological survival, right? But the big takeaway is that if you give it after the patient's been down for a while, it's going to increase survival with the good neuro outcome and survival with the bad neuro outcome. So it's not going to show a difference at the neuro outcome level, if that makes sense. And it's obviously really hard for us to tell in the pre-hospital realm how, we don't always know how long the patient's been down and how is their brain going to do. We can't tell that. So it's not really reasonable to kind of pick and choose who we give epinephrine to. So really the big takeaway from epi is we give it just in case that patient does have a better neurological outcome, but it does not necessarily correlate directly with that, if that makes sense. The other thing about epinephrine is that the less controversial is that earlier administration is better. Every minute of delaying delivery of epi in a non-shockable rhythm is associated with a 2 to 6% decrease in RASC and 4 to 10% decrease in favorable neurological outcome. So even though we can't agree whether it helps or doesn't for your neuro outcome, we can agree that giving it earlier increases those chances. When we're talking about shockable rhythms, sometimes that changes because you'd rather shock the patient than give them epi. So some protocols have you wait until after 3 shocks to give epi. And that's why, because we're going to prioritize shocking and good CPR. But it kind of makes sense, right? They need epinephrine more than, or excuse me, they need cardioversion more than they need shock defibrillation more than epi. You guys know what I mean? All right. Now the big thing is also the route of epi. So there's been some studies that show that IO epi may actually have an inferior outcome compared to IV epi. And this doesn't actually just apply to epinephrine. There was a systematic review back in 2020 that looked at IV versus IO, which was mostly a pretibial IO, drug administration during cardiac arrest. And they basically found that the IV route had better clinical outcomes compared with IO. So the takeaway is if you can get an IV, try to get an IV. If you can't, or if it's going to delay other more important interventions like CPR and ventilation and shocking, then do an IO and we'll continue to do more research. And then if, in case anyone had any questions, the AHA discourages intracardiac drug administration since 2000. And endotracheal drug administration is also discouraged, not just because it's kind of fallen out of favor because we have better options. We have IO and better IV access and everything else, but also because it's results in a pretty low blood concentration and it's pretty unpredictable. You can't really predict how well it's going to absorb. All right. I do have a question about that vector change and if that would equate to time away from compressions while things are moved. That's a great question. And if that would be like kind of worth the outcome. I don't remember if that study specifically addressed that, but I think if you're a high performance agency where you train a lot on this, the goal would be to train on kind of doing that quickly during a pulse rhythm check. And so to kind of minimize that time, right? Because again, you want to keep that under the 10-second pause. So as long as you can get to a point where you can do that quickly, then it would be worthwhile to consider the vector change. If it's going to take you 20 seconds to do it, then yes, I would say that would be maybe not worth the outcome. Good question.
Would it be beneficial to put patches on when you initially do as a backup?
Like a second set just to be ready to switch?
Yes.
Yeah, that's a good thought. If it's not taken away from your pause duration. Yeah. It's a good thought. All right. One last controversial topic. We're going to talk about which antiarrhythmic to use, amio or lido. So this was a trial from 2002. And it really kind of drove out of hospital cardiac arrest care for a while with regards to which antiarrhythmic we use. This was amiodarone as compared to lidocaine for shock-resistant VFib, aka the ALIVE trial. But it is still a pretty noteworthy trial to discuss, even though it's 22 years old. So this was a randomized control trial where they really wanted to look at whether amiodarone or lidocaine would improve survival rates, as well as some hospital admission and some other stuff, specifically in, obviously, patients with shock refractory out of hospital cardiac arrest. They ended up getting 344 patients who had VFib, had gotten 3 shocks and epi, and then a 4th shock, and they were still in VFib. And so they got either IV amiodarone or IV lidocaine. Did a pretty good job of dividing those. And primarily they looked at survival to hospital admission, which amiodarone had better survival percentage compared to lidocaine. And then they looked to some secondary outcomes, survival to discharge from the hospital, which was a little bit better. And then treatment for bradycardia. This was a kind of really secondary outcome that I'm not going to talk about. So the big takeaway from this study was that when compared with lidocaine, amiodarone actually led to higher rate of survival to hospital admission in patients who have shock-resistant out-of-hospital VF. Since 2002, there's been quite a few studies that kind of disagree with these findings. Some say lidocaine has better outcomes. Some say lido and amio have the same outcomes. Some say that neither of them make any difference when comparing with a placebo. And if you talk to a cardiologist, they really like lidocaine a lot of the time. And the AHA did update its algorithm a couple years ago to re-include lidocaine. So there's not really a definitive answer here. And obviously the answer is always going to be do what your protocols and your medical direction tells you. But just so you're aware that the 2002 study is kind of why we weren't using lidocaine for a while. And now maybe we're bringing it back, but maybe we're not. The data is not quite stone cold there. And in regards to some other medications that we give, there's actually no evidence for empiric use of calcium or sodium bicarb unless you suspect something specific. So hyperkalemia gets both. If, it's a dialysis patient who goes into arrest, for example. If you have a calcium channel blocker overdose that goes into arrest, then certainly reasonable to give calcium. If you have a sodium channel blocker, right, certainly reasonable to give sodium bicarb. But just giving it empirically, so just kind of treating every cardiac arrest with these 2 medications shows no evidence for improved outcome. And sodium bicarb actually may even worsen your survival and may even worsen neurological recovery. So that's where we're kind of being cautious with those medications. All right, so you did some amazing CPR. You shocked right away. You gave epi, maybe you gave an antiarrhythmic, and then you got the patient back. Great, they have a pulse. What now? So the goal of post-ROSC interventions, really the big takeaway is to try to mitigate injury to the brain, right, and other important organs. And the big threefold way we do that is through blood pressure management, 12 lead, and oxygenation. For blood pressure management, you want to avoid hypotension. Ideally, you want to keep that systolic blood pressure at 90 and above, that MAP of at least 65. And this one is kind of like a no-brainer, right? Low blood pressure is going to worsen oxygen delivery to the tissues. And so it's going to cause, brain damage or worsen brain damage and cause damage to other vital organs. There's a bunch of studies that kind of confirm this. They found that there's worse outcomes if you have hypotension, both survival and worse neurological outcome. You're going to do that with fluids, pressors, depending on what the national shortage of the day is at the time. But this is really where that rural twist to this talk and to management of out-of-hospital cardiac arrest really comes in. Because you may have to manage this blood pressure for a really long time, right? And the tools for blood pressure management that you have, if you're driving 50 minutes, are going to be very different than if you're spending 5 minutes with that patient. And then the other takeaway from this is you really have to be ready for that patient to re-arrest and crash again, right? So keeping a close eye on that blood pressure, doing your best with the medications you have at hand to keep it up, and really being ready to restart CPR and resuscitation if they crash, because it's going to be more likely to happen in a longer transport than a shorter transport. And then if you're a BLS only unit, considerations are you going to try to rendezvous with an ALS unit? Is there one nearby that can, join up with you and kind of help with that blood pressure management with all the tools they have? Or are you just going to go to the nearest facility? The 12 lead. This is obviously to look for a STEMI, because a STEMI is something that we can intervene upon in somebody who's had a cardiac arrest. They go to the cath lab, they get a stent. But doing a 12 lead in an urban area where the 3 nearest hospitals are able to do cath lab is obviously a little bit different than if you're 45 minutes away from the nearest 3-bed ER. And so that's why the 12 lead is really, really important. Are you going to have to fly this patient out if there's a STEMI, right? Are you going to have to rendezvous? Are you going to have to take them to the nearest hospital and then they fly them out, right? So all of those considerations that are very, very different in the rural realm. And then finally, oxygenation. This is also pretty straightforward. You want to make sure you avoid hypoxia and do so by whatever means you have available. The other thing for a rural kind of perspective on this is if you have the patient for long enough, are you going to start considering titrating down that oxygen, right? Not only just to kind of keep that SpO2 of 92 to 98, but, try to avoid hyperoxia. You're not really worried about hyperoxia on these patients. You're not worried about giving too much oxygen, but it's, if you're going to be with them for 50 minutes, maybe try to conserve your oxygen resources and titrate them down while keeping them within that frame. And then the end-tidal CO2 is also that fourth component that I didn't discuss. We really want to make sure we're not hyperventilating or hypoventilating these patients. Another twist on kind of rural oxygenation and another controversial topic is whether to intubate or use a supraglottic airway in the pre-hospital management of out-of-hospital cardiac arrest. This was a pretty big trial back in 2018 that really kind of rocked the EMS world. But I'm not going to go into depth on this. I'm not going to go into depth on whether iGel or whatever other supraglottic airway you have versus intubation has a better outcome, because this could be a talk for hours in and of itself. And it's quite controversial. But my general advice is, beyond talking to your medical director about it, secondarily, just go to your strength, right? If it's an agency that, or a provider perhaps that hasn't had an intubation in a while and the chances of success are lower, then maybe you're going to go with an iGel or whatever SGA you have, or if the conditions aren't good, right? If you're going to have a prolonged transport, then the iGel may not be adequate or the SGA may not be adequate. So the logical next step would be to get a definitive airway. And then certainly there's a caveat there for the type of arrest. So if it's an arrest that is because of a primary airway breathing hypoxia situation, like a drowning, anaphylaxis, etc., then that definitive airway is going to be a lot more important than in a patient that we think is more likely a primary cardiac arrest. But the big takeaway is when you're taking care of a patient for a long time who has RUSC after an arrest, there's certainly a lot of times where securing a definitive airway, if it's within the realm of possibilities for the medications you have and the tools you have at hand, is going to be the way to go. Compared to perhaps a BLS airway. All right, and because this area is near and dear to my heart, I can't really do an out-of-hospital cardiac arrest talk without talking about some disparities in out-of-hospital cardiac arrest care. This can and has been a talk that can last many, many hours, but I just wanted to briefly mention it here. There's disparities in CPR training. At the population level, you're less likely to receive CPR training if you live in a primarily Black neighborhood versus a white neighborhood. For 911 access, there's data that shows that certain ethnicities, such as Hispanic, is less likely to access 911 in the context of cardiac arrest. You are less likely to get bystander CPR or an AED use if you're a female than if you are a male. And even in the care of EMS providers, sometimes we see some disparities like timing of epi and other things. And there's certainly disparities at the hospital level too. Beyond the scope of this talk, just wanted to mention it. And then there's also an argument to be made about the importance of gathering data and reflecting on performance, whether that's at the agency level, the county level, the state level, etc. Improvement is going to start with collecting data, and evaluating that data, right? And so looking at resuscitation performance and outcomes is going to be the way to really improve the care we take of these patients. There was actually a review that looked at this and found that there was improvement in cardiac arrest survival in organizations that implemented cardiac arrest registries. So just having that data and looking at the data is sometimes enough to kind of make you better at this. there's a bunch of different ways to do this, right? Big volume agencies have fancy equipment that gives them the exact information that they need to know, but that fancy equipment is very expensive. And so whatever this looks like at your agency or specific level, just kind of emphasizing looking at the performance and outcomes in whatever way you can. And finally, since this is a training on cardiac arrest, I need to justify my existence here tonight and talk about the science that supports the training. So this is a booster training, and there's a lot of recommendations, specifically the AHA as well, to have some booster sessions when we're using kind of this mass learning approach. So we all learn, like, you know, ACLS or BLS. We learned that in a massive classroom most likely, but these booster sessions can be really helpful to retain that information. In addition to these booster trainings, you want to do that space learning, right? So obviously every 1 to 2 years is kind of that time where we start to think about doing CPR training and everything else again. And then that's associated with better retention over kind of like 12 months. For those of you guys who are listening in from agencies out east, where we do medical direction, this will be tied in with the training we're doing in person over the next couple of days. Turns out that incorporating kind of this space learning and everything else into simulation training and hands-on means that you retain it better. So that's where we're kind of pairing these two things together. And then any of you guys who aren't, I recommend, if you can, do some CPR training with your agencies in the next couple of weeks, if you're listening, just to fully kind of integrate that training.